Okay, thank you so much, Dr. Iman, and thank you, Naifa and Christine. It's a great pleasure to be here. I have two cases to discuss. Try to finish them in around 30 minutes and take it from there. Okay, so let me share my screen. Do you see my screen? Yeah, okay. So I have nothing to disclose, and I'm going to use a voting system again for the audience to participate. We want this to be interactive. So you may scan this code, or you go to this site and put the ID of the meeting, and you will be part of the voting system. I'll just give it a few seconds for people to join. Okay. So to test the system, let's start with this slide. This slide is about where you are practicing, and we'll start the vote. Trying to get accustomed to the system. Still not seeing the numbers. Can somebody assure me that you hear me? Perfect. Okay, great. So, oh, okay. One more time. It doesn't show up. Let me see myself. Mm, it does not seem. Yes. Sorry. The first one. Okay. I am connected to the meeting. And so, okay, the result present. Let's move on and see. I think it will work. And if it doesn't work, we can discuss the cases without this. But anyway, this is a 68-year-old lady who felt pain in the upper part of the left hip while she was taking the stairs on a cane. Over the next few days, the pain got worse. She was evaluated in a local hospital, and they found that she has several lytic bone lesions involving the left trochanteric area, the sacroiliac joint, the ribs, the scapula, and the left scalp. She has history of diabetes and hypertension, and she is elderly. Her family history was positive for a mother who died with esophageal cancer, and she was referred to us in January 2024. When we saw her, she was elderly, frail, bedbound, normal vitals. She has large left skull mass that I will show you in the CT scan in a minute. And she has huge nodular goiter of about around 200 grams, mainly on the right side with deviation of the trachea to the left, several right-sided large firm lymph nodes. The rest of her examination was unremarkable. And just to get to just give you an idea about the extent of her disease, I'm going to run this PET scan. So this is the scout here. You can see a huge mass in the right side of the neck. You can see some lung metastasis, and you can see the left hip lesion. And I'm just going to show it in axial view. Um, so you can see the hip lesion will appear soon. Okay. Here you can see it. You can appreciate this very well. And some spinal, sacroiliac joint, and sacrum, some vertebral metastases. And then as we go up, we're going to see more and more um, something in her lower lung, field, ribs, and then the mass itself in the neck. You can see huge mass. And then farther up, we're going to see something in the skull here, which was palpable and large mass. Okay, so on the CT scan, again, you can see a mass, a huge mass in the neck. Again, I can run this quickly so you can appreciate the anatomical extent. This is going down in her superior mediastinum, compression of the trachea. Rib lesion. And you probably see on the right side here the skull metastasis around 5 centimeters. Quickly just going down to the pelvis. And this is the head lesion. It's it's also very big. I'm trying to get the measurement. Okay, so it's a big lesion, 5 by 6 centimeters. Okay, so I think it's clear that this patient has probably a thyroid cancer with extensive metastases. This is the laryngeal exam. It showed basically mobile vocal cords, which was surprising, but unpatent upper airway, and FNA showed follicular neoplasm. So the question here, how would you manage this patient? And basically, should we start with the thyroid, with the head, with the thyroid and head together, skull first, or another suggestion? And again, let's try this coating system. I hope it works this time. Seems so. I'll give it a few more minutes or seconds. Okay, let's see how people learn. So most of the people would like to tackle the thyroid and the head together. Naifa, regardless of the question, would you give us your comments on the case?
Yeah, so this poor lady, her performance.
that's a conversation you would have, because in an elderly lady with comorbidities, it's nice to be at least ask that question. Otherwise, the reason the people that picked thyroid first was because if you can do the total thyroidectomy and get some iodine in, the problem is those bone metastases are so big that iodine's not going to solve that, right? So that's going to need a hip surgery for sure. And so I think it's a conversation with the surgeons, but in an ideal setting, they would do three, thyroid and hip.
Excellent. Okay. So this is what happened. She actually, as you said, she had a fracture of the hip. So it would not make sense to operate on the neck when there's an emergency in the bone. And she underwent actually left proximal femoral replacement under epidural anesthesia because this patient is frail and high risk for general anesthesia. This is the description of the surgery: proximal femur resection and reconstruction by mega prosthesis. She stayed in the ICU for a few days. It was uneventful, probably because we used epidural anesthesia. And the pathology, as suspected, was follicular thyroid cancer. 1 month later, she went for palliative external radiation to the T7, which she has metastasis in lumbosacral spine and also the scalp. So 4 months later, she was admitted for thyroid surgery. And this is the first time I was involved in her care. She was not stable. I was called by the surgeon and he took me to the patient and say, you want me to do surgery for this patient who is having stridor? She was bedbound. She is definitely in a very bad shape. So the question, what should we do with all of this? The patient still have the primary disease there. The only thing that we could do is to fix her hip. She has extensive metastasis, aggressive disease. And the question here, what should we do? Let's see our audience, what they think. Should we just do palliative care, no further action, give her more external radiation to the neck, start tyrosine kinase inhibitors, or think about something else? Okay. All right. So let's see what people think. Okay, so the majority thinks about palliative care, no further action, 0, external radiation, 0, tyrosine kinase inhibitors, 37%, and 19% something else. I don't know if Christine is with us or just Naifa. Maybe only Naifa. Okay, so Christine is for the benign thyroidology and Naifa for the malignant ones. Okay, Naifa, what do you think? What would you do with this patient who is really sick?
So again, this is really tough because I'm not sure why, she's really sick, and maybe it's because she's had a lot of pain for a long time and had to deal with this. But anybody who's that sick, we always want to assess, just like one is being assessed for surgery. What is their performance status? Meaning, what can they do? Can they get out of bed? Are they able to walk? So typically to withstand any sort of chemotherapy, tyrosine kinase inhibitors or surgery, they typically need to be out of bed more than half the day. That's the, otherwise they go downhill and don't do well. And in this case, the patient has stridor, and I don't know if that mass had rapidly grown or why she developed that stridor, but that's not a good sign because she just went through hip surgery. And that, mabruk to you and your team that you were able to do the hip surgery under epidural. I think that's very impressive and very thinking out that it was great. So in this case, she's not going to be able to stand a tyrosine kinase inhibitor. The question is, and in general, radiation to the neck with such a big mass that's causing stridor is going to worsen her breathing. You can do palliative care. It would be nice if she has stridor, so you need head and neck surgery there to help you with at least steroids or something to get her breathing to see if she can stand anything else beyond palliative care. So if you can get you have the tissue, if you could send it for molecular testing. The problem with follicular thyroid cancers is they're often RAS mutations, right? So they're not targetable. So that's not necessarily helpful. So I think that in this case, we just have to be really, really careful and see. It's none of these options on this page are good for her right now. She just can't breathe.
Sure. So as you said, Naifa, she was in a very bad shape. She was having stridor. She was bedbound. Her family is very, very, very interested to do anything to save her. She has a son and a daughter who was really very adamant about doing something. So, and the surgeon who pulled me to see this patient is actually ENT surgeon, an experienced actually thyroid surgeon. But when they were planning to take her next day, he went saw the patient. The patient obviously was not doing well. So here's what went on. We did oncomine cancer gene, and as you predicted, she has NRAS mutation only, so there's no targetable gene. So we had a long discussion with the family, and I clearly told them that I can start her on lymphatinib if it is acceptable to you, but with these complications, with these potential complications, or even more, bleeding, fistula, thrombosis, kidney damage, perforated vesicles, hypertension, diarrhea, skin changes, or death. So we had a long discussion, and they were really willing to take the risk. So we started this patient on lymphatinib at 40 milligram daily, and it was advanced slowly to 20 milligrams. Surprisingly, she tolerated it. I saw her after 1 week and 2 weeks, and there was improvement in the stridor and the difficulty in breathing. And even she noticed that her skull mass started to soften. This is her mass initially at the beginning of lymphatinib, and let me just skip this because this is exactly what I showed you before. 2 months later, we start to see some changes, not very, very impressive, but you can see the mass is probably smaller than before. It was smaller than before by measurements. And even the neck mass, this is around now a month and a half later, and the mass in the neck also started to be softer and less tense. You can probably appreciate it if you remember what we saw earlier. But more important is not 6 months later, it's around 6 weeks later, 6 months later is in December 2024. She was started in April, and in December 2024, you can see no mass in the skull at all. And when you go down to the neck, you can see the mass has shrunken big time, and now is probably okay for surgery. She has pleural effusion at that time, but we dealt with it. So 1 month later, this is her PET scan, and this is the mass, I'm sorry. And this is the mass, and again, to give you an overall picture about this, the size of this mass, it's even hard to believe that this is the mass that was there 6 months earlier. Continue to have pleural effusion. This is a PET scan that shows you the mass has become much smaller. There's no much of activity in the left head. There's a scattered metastasis in the lungs and the spine. And even here, this is the prosthesis. So, okay. And this is the PET scan again, the follow-up PET scan. You can see there is no mass anymore in her skull. And as we go down, the neck mass has become much smaller. And the trachea is becoming patent. Moderate pleural effusion on the right side. There is metastasis in the spine, number of lesions. And then as we go farther down, we see some, again, metastatic lesion there, and then the prosthesis. So we start to think now about surgery, and she's in a much better shape than before. And indeed, she went for neck surgery in February, 2025, around 10 months later. The surgeon did right hemithyroidectomy. Remember, the tumor was on the right side, and he did central and right neck dissection. Of course, I was not quite happy with hemithyroidectomy for this patient, but his justification is that she has metastasis anyway. The left lobe will not add much, and we removed most of the disease, and I did not want to risk her left focal cords. We were happy with this, considering the initial situation of the patient. This is the pathology. So the pathology is poorly differentiated thyroid cancer, 7 centimeter at that time after many months of lymphadenopathy. It has high mitotic count. It has necrosis, so this is why they call it poorly differentiated. And this is basically the stage of the disease: T3B, N1B, and of course M1. So she is stage 4B. So the question now, what would you do when you see this patient in April this year, 1 year later after lymphadenopathy for 10 months and neck surgery, and prior to this she had also hip surgery? Would you send her back for further surgery to take the left lobe, give her radioactive iodine, just continue lymphadenopathy, consider immunotherapy, that she has poorly differentiated and has metastatic disease, just observation, something else? And I'm again going to give a chance for contribution. Okay, let's see what people think. Okay. So the majority will continue lymphadenopathy. 13% will give radioactive iodine. Interesting, more than this, double this would do immunotherapy. Nobody will send back for surgery, observation, something else. Naifa, your comment, please.
So first of all, let me go back and comment that this is amazing. Okay, this is not, I don't want the audience to think that this is normal. So from so many points. So let me start from when the patient, was breathing, was very frail to begin with, but was breathing okay, then rapidly went into stridor. So Dr. Ali Zahrani was thinking this is something obviously really bad, but this might be something working on the spectrum of anaplastic thyroid cancer, because why did she have breathing problems, right? That was so quickly, right? Unless she had it in the beginning and we just didn't note it because she was so weak. And then to have that and then he took a chance, right? Because usually when you have a poor performance status, you don't start targeted therapy. The exception to that is when somebody's acting like a very poorly differentiated anaplastic and you think you can improve the performance status with targeted therapy, which is what Dr. Ali Zahrani was thinking when he saw this patient, which is amazing that the patient and the family agreed and he thought of that. So he started a low dose lenvatinib because the FDA the approved dose is 24 milligrams. And the patient had a rapid response. Okay, so in general, with differentiated thyroid cancer, having a response within 2 months is in the trial, you could see that, and then up to 2 to 6 months is when you could see the nadir, right? So you saw that in her. He showed us a 6-month scan, but this patient had a more than phenomenal response. Okay, so had bone response, which is not very common. They can have bone response, but not the way she did. She had big bone disease and she responded. So this was great. So my hat's off to Professor Ali. This was great that he did that. And I'm really glad this lady did well. Now, knowing all that this was an unusual response, you could look at it and say, wow, I think this is acting much like anaplastic thyroid cancer, right? A RAS mutated, pathologically it's called poorly differentiated, but it grew rapidly to cause stridor. Now it had this beautiful response, and including response in bone. One of the problems is that response often doesn't last, right? So I can understand why the surgeon did a hemithyroidectomy, because he was probably worried that her only remaining cord may go out. And if he loses that, she's, is a trach. So I can understand why he did that. Although again, we're way off guidelines at this point, guys. Right?
Absolutely.
So if you decided to do a total thyroidectomy, then you could do iodine. You can't do the iodine without the total thyroidectomy because it's going to go to the normal thyroid. But a RAS mutated, we haven't heard what the thyroglobulins are the ones that potentially are going to respond. So it's interesting that you did that.
Yeah, I think the trick here, and I was actually building on that, that this is follicular thyroid cancer, highly vascular. And I trust lymphadenant in this situation. The only problem, it is difficult to give it a patient who was near death. And she could have easily developed fistula that because that mass is compressing the trachea. But again, this has been after a very comprehensive discussion with the family, and they were very adamant. And I wanted to do it actually because the patient needed help. Otherwise, she would have died. Now, this is her scan after the surgery. The surgeon took the right lobe, yes. And he did extensive lymph node dissection, which was for his credit. He left only the right lobe. And it's surprising that if you look at the uptake, it's only 2.6%. Although theoretically he left the right lobe. Now, talking about thyroglobulin now, if you can see the thyroglobulin at the bottom, it was more than 5,000 with negative antibodies. And this was stimulated by thyrogen. We did not want to take her off thyroxine for her medical condition, also to avoid any progression of the disease. So we went ahead and gave her radioactive iodine, 190 millicurie. And she was ambulatory enough to be isolated. In our country, we still isolate those patients in a room. She was okay with occasional help from her daughter. You can see the post-therapy scan, the tumor, the metastatic lesions are taking up iodine, and of course, the thyroid remnant. And I think the question here again, so we can move to the next case, is what's next? This is only back in April this year, so it's like a month and a half or a month ago. So should we resume lymphadenant after radioactive iodine? No further intervention at this stage and just evaluating 4 to 6 months. I know immunotherapy is not conventional, but I just want to increase my choices here. So again, for our esteemed audience, what would you do? Okay, great. So let's see what are the... So many of our people here want to resume lymphadenant. Some think that the patient had enough lymphadenant and radioactive iodine now on board, and we can evaluate this patient in 4 to 6 months. See, still people are excited about these fancy things. Immunotherapy, 15% would like to give her immunotherapy. Naita, what is your opinion on this?
I think this is very hard, right? This is one of those where we would discuss it in conference and different people who had different opinions, to be honest. Because the question is, here's the patient. I don't know if her performance status presumably is still good.
That's good.
It's impressive that you could give radioactive iodine and that much thyroid was removed and that you only had 2.6, like you said, percent uptake. Because if you have half a lobe, usually you get a lot more uptake than that, and it sucks it up and you don't get uptake. So again, a really cool story where they took up iodine and you took a chance, and I think that's neat because lenvatinib, usually we've never proven that it can redifferentiate to cause uptake in radioactive iodine. So I think either one or two would be good options. Whether you decide to resume it or give her a break and then see how she does. I would probably do her in 3 months. If I can pick something that's not on the sheet here, and then just see her back and see what's growing. I can also consider radiation in the armamentarium if any of these are painful. Sometimes the hip surgery, even though they operate on her hip, they want us to consider radiation for that, although it's been a while since that. And any of the other lesions that either didn't take up iodine, I would consider radiation for, especially if she had pain. Otherwise, I think it's fine. See her back in 3 months and let's see what happens. So we would love for you to come back and tell us what happens in 3 months.
Sure. So what I did, again, realizing that she has an aggressive disease, I wanted actually to make sure that she is safe until I evaluate her. So I put her back in lymphadenant, thyroxine, and I'm going to see her in 3 months for evaluation. If everything is under control at that time, Of course, we are seeing her in between. It's not 3-month appointment. We are seeing her for complication of lymphadenum and her general condition, but formal evaluation for the extent of the disease will be undertaken in 3 months with PET scan and maybe CT scan. And if things are under control, I will stop lymphadenum and follow her up. If she has active disease, then again, lymphadenum is a good thing for her. So that's basically it. I don't know, Dr. Iman, if I have time for the second case or you want me to stop here. It's still also interesting case, very interesting case.
Yeah, unfortunately, Dr. Ali, thank you very much for this amazing case with unbelievable response. So unfortunately, we had an extensive discussion of one of your amazing cases. For the sake of time, we would like to move on to discuss a different flavor of cases, if you don't mind. Okay, so
Sure.
Switching gears, we'll be discussing a different flavor, benign cases. We have our panelist, Dr. Christine Bauerlet, Professor of Endocrinology at the University of Birmingham and a consultant endocrinologist at University Hospital of Birmingham. Professor Naifa Al-Busaidi, Professor of Department of Endocrine Neoplasia and Hormonal Disorders, University of Texas, MD Anderson Cancer Center. So let's start off with the first benign thyroid case. Does that pointer? Yeah, okay, here we go. So the first case, we have a 38-year-old female presented with palpitation, weight loss, heat intolerance, and tremors. She went to a primary health care, and her labs were consistent with the picture of thyroid toxicosis. And she was started on bisoprolol and referred to an endocrinologist. Her thyroid function test shows a picture of thyroid toxicosis, and her baseline labs, a full blood count, demonstrating a normal full blood count. A question here, Dr. Christine, why are we interested in a full blood count in a thyroid toxic picture?
Yeah, thank you. Can you hear me?
Yes.
I presume because you're thinking that you're going to start anti-thyroid drugs, you want to make sure that the neutrophil count is fine before you start it. And of course, often neutrophil count is not fine in patients with thyrotoxicosis because of thyrotoxicosis per se.
Yes, okay. In terms of liver function test, her GGT were almost 5 upper limit of normal, and she had an elevation in the transaminases. So she has both pictures in terms of elevation, transaminases and a biliary abnormal elevation picture. Vital signs were fine, and thyroid exam reveals a presence of thyroid eye disease signs. Her goiter measures 60 grams, and it was a rubbery goiter. At this point, based on the clinical presentation and part of this lab demonstrated, can we put together a diagnosis at this stage, Dr. Bauerlet?
So it looks like she has thyrotoxicosis because of her, I don't think her eye disease is convincing that this is Graves' disease, but I'd like to have a TSH receptor antibody measurement.
Perfect. So most of us will probably use more than one resource to confirm the diagnosis of Graves' disease. But clinically, with a picture of thyroid toxicosis and the presence of 2 physical exam evidence that this is a picture that fits Graves' disease, some of us would diagnose Graves' disease. Now, the testing thyrotropin receptor antibodies, you would need it as a baseline to determine the response of your medication or response of the disease to the medication, and also to decide the severity of the disease. What do you think, Dr. Bauerlet, about this?
Yeah, that's certainly my first line investigation in a patient who presents in this way. We need to monitor response to treatment, and it gives an indication of severity, because that also has then implications for treatment choices. Because if it's very high, we know that anti-thyroid drugs almost certainly will not induce a remission.
Perfect. What about the abnormal liver enzymes and the bilirubin, the biliary picture elevation? Would that hinder you from using a certain thionamide to treat Graves' disease?
Yes, so it's a thyrotoxicosis causing this, and we see this in patients with thyrotoxicosis, that liver function can be upset. I wouldn't like to use propylthiouracil in any case. I would only use that in selected cases, but I would definitely be more worried about using propylthiouracil, and I probably would be a little bit worried about using carbimazole here as well.
Right. So in terms of experience and evidence as well, which one is having less severe side effects when it comes to liver disease, PTU or methimazole/carbimazole?
Well, so PTU has got the bad name about
Right.
liver disease. You get a different picture. You get a hepatic picture with PTU. You get a cholestatic picture with carbimazole. I have seen both pictures with both. Like I said, I rarely use PTU except in women trying to become pregnant in the first trimester of pregnancy. I definitely wouldn't use PTU here. If I would use carbimazole, I would do that under careful monitoring, but I would like to investigate the liver first.
Yeah, so with the presentation of Graves' disease by itself will play with the liver enzymes. And when we do see this picture, I personally would start thionamide anyways. The only place I would use PTU is the first trimester in pregnancy or preconception, to be more correct. Otherwise, we will go ahead with the methimazole/carbimazole in this case, which will improve the liver enzymes. So further, to confirm the diagnosis at this particular institution, the anti-TSH receptor was performed, and it's clearly very high. And on top of that, an uptake and scan was performed, which demonstrated a diffuse total uptake. Obviously, you don't need that much confirmation of the diagnosis. In my clinic, I would rely on the clinical exam, but the anti-receptor TSH antibody I would use to determine the severity of the disease and to monitor response. Dr. Barlett, would you perform an uptake scan?
No. My protocol is we do TSH receptor antibodies. If that's not raised, then we do a technetium scan.
Mm-hmm. Okay, so we've discussed that. Would you initiate thionamide therapy? So unfortunately, with this case, the team did not start thionamide therapy, fearing the elevated liver enzymes, in particular the GGT, which was almost five-fold upper normal. So they have referred this patient to investigate further her liver picture. So with that elevated liver enzyme, they have referred to hepatology and have tried a trial of cholestyramine. Dr. Barlett, would that be your second choice if patient did not tolerate a thionamide?
Yeah, so looking at this slide, I would definitely, so if this patient presents to me, I'll request an urgent liver ultrasound, I'll request an autoimmune liver screen, and I do a hepatitis screen. And I'll probably speak to a friendly hepatologist, say I've got this patient. If I'm too reluctant to start carbimazole here, and if I start carbimazole, then this patient would have weekly liver function test monitoring if I did that. And obviously that's assuming that the other liver investigations are negative. I have used cholestyramine, it works well. Mm-hmm. I have used lithium. That of course has more side effects, but again works well. But this is a patient where I think you may have to consider definitive therapy early. And if that is the case, then you could block with iodine. And I think probably with this whole picture here, and it again depends on your setup and what relationship you have with the surgeon. But my surgeon will be present in my clinic when this patient comes, and I'll say, we'll take this thyroid out pretty soon. Let's give some iodine, get it controlled, and take the thyroid out.
Yeah, so this type of case we do discuss in our thyroid multidisciplinary meeting. We discuss such cases and also parathyroid cases. Now, my experience with the cholestyramine is it does work very well, but unfortunately this patient did not tolerate cholestyramine. So a bit of evidence on liver injury in Graves' disease. So it results from the direct toxicity from excess thyroid hormones and also from the autoimmune mediated liver injury, the autoimmune process that's going on. Predictors of hepatic dysfunction in Graves' disease. So age, if it was more than 45, duration of Graves' disease, prolonged duration of Graves' disease, a high cardiovascular output sign, and TRAB. TRAB is very important here. So in ours, it was very important, almost 9 folds upper limit of normal. So if you have a very high TRAB, that predicts severity of Graves' disease and the severity of hepatic dysfunction. High free T4 as well goes along with the severity of Graves' disease. So this patient had the rest of her liver workup were negative, immunological markers, and eventually she had a liver biopsy which has shown very normal findings, mild focal perioral inflammatory changes, that is from the autoimmune process going on with the Graves' disease, no granulomas seen, no necrosis or fibrosis. So basically normal liver biopsy apart from mild focal periportal inflammatory changes that comes along with the Graves' disease. So cholestyramine was not tolerated. Prednisone was started as an alternative to control thyrotoxicosis. So you've mentioned, Dr. Barlett, that lithium was tried. So can you tell us your experience about lithium? I would do it as a third line. So what would be your experience in such a case?
Yeah, again, for me, it would have been a third line to add lithium. So again, in my experience, it's a few number of cases, but it has worked well. Of course, lithium is not without side effects, and again, requires very sort of close monitoring. And I think when you get into that territory and the patient is fit enough to have surgery, I think that is just overall, because that's a discussion I have with these patients. Look, we're clutching at straws here. Anti-thyroid drugs make us nervous. Any of those other treatment, you don't tolerate cholestyramine, which doesn't have that many side effects, but you're not tolerating it. We're now going to drugs that actually have significant side effects. Why not take it out? Because in the end, you are going to need a definitive treatment. This Graves' disease is not going to be cured with anti-thyroid drugs. So let's just bite the bullet and do it.
So remember, definitely she needs a definitive treatment, but to bridge her to that definitive treatment, we need to lower down those free hormones in order to reduce the risk of cardiovascular collapse in this patient.
So I'd give potassium iodide for that.
Potassium iodide. Yeah. Okay. For how long? Like 3 days?
No. So generally, I've given it up to 2 weeks in patients with Graves' disease, because of course what we worry about is that they will escape the Wolff-Chaikoff effect and that they become very thyrotoxic. But even people with extremely, very high levels of free T4 within 2 weeks, generally, I have their thyroid function controlled such that an anesthetist does not get nervous. And generally, our anesthetist, so my upper limit of normal for free T4 is 20. If free T4 is around 25, they're happy. And sometimes when it's less than 30, I say, just man up and take this patient to theater, and we do.
Provided she's well beta blocked.
Indeed. But she was beta blocked, right?
Yes, bisoprolol was started to target a heart rate of 75 beats per minute. So an interesting phenomenon, Dr. Barlett here. Depending on the region of where you treat patients. So here, our region is an iodine deficient region. And if we did start Lugol's iodine, we do see the escape, and patients would precipitate with worsening of the hyperthyroidism. So I've seen one case.
After 3 days.
Yeah,
right.
Because patient was not pre-medicated with the prednisone, so not this case. So what do you think about patients with prednisone in iodine-deficient areas before giving them Lugol's?
Yeah. So I generally don't have to do that. We are only, if anything, we're mildly iodine deficient in the UK, possibly a little bit in pregnant women, but you know, it's the evidence isn't all that clear. But yes, in that situation, I would also use prednisolone. But again, I think potassium iodide works. Lugol's iodine or potassium iodide tablets work extremely well in this situation.
Perfect, okay. So these are the alternative therapies for hyperthyroidism or Graves' disease. So cholestyramine was not tolerated in our patient. Corticosteroids was started. Potassium iodide, as mentioned. Just pay attention to the discussion we had recently. We just had now based on iodine deficiency or minimally iodine deficient area or region, if they would escape the Wolff-Chaikoff phenomena. And lithium, indeed, is an alternative to try. So with that prednisolone, if you look at the trend of her free hormones, so you would see that the free T3 and free T4 pointer. So cholestyramine was started here, but it wasn't, unfortunately, tolerated by the patient. So prednisolone was started in an aim to have some control over the disease. So if you look at the free T3, free T4, they started to trend down. And here, whereby carbimazole was added comfortably by the team.
Can I ask, did the liver
Sure.
function improve?
Okay, so a very good question. Yeah, so if you look here at, I actually kept that till the end. So if you look at the GGT, which was the main concern, so that line represents the GGT, which was the main concern in our in that case. So it was trending down. So the moment you treat Graves' disease, you would expect trending down of transaminase or the GGT.
And I guess the steroids might have helped here as well.
Yeah, to some extent. Now, with the elevation liver enzymes and the GGT, in my opinion, and you know, what I would personally do is still try carbimazole, which you will, you know, obtain beautiful results in terms of improving liver function, intestine liver enzymes. So the learning points from this case is thyrotoxicosis alone can elevate liver enzymes, even in the absence of medication. So that's important to note before you start your medication. Current guidelines advise caution with thionamide if transaminases were exceeding 5 upper limit of normal. And the liver enzymes will improve with the treatment of the Graves' disease or the underlying cause. So do we have time to discuss another case? Okay, so we do not have time to discuss another case. Yes, we've covered all these cases. Just one last point here. Yeah, when do you consider early referral for radioactive iodine or surgery, Dr. Barlett?
Yeah, so I think in this patient, so I think any patient either who is intolerant of anti-thyroid drugs or where anti-thyroid drugs cause a number of management concerns, like in this patient, you know, I probably will have given, like you, some carbimazole, but I would have been very nervous about it. I think early referral is important, especially because many of these patients will have very severe Graves' disease, and we know that they will end up with it anyway. Radioactive iodine obviously is less invasive, but it'll take much longer to get a cure. And I think, again, depending on your setup, my preference in this patient, if you ask me to choose one, and because, you know, we have to discuss all the options with the patient, but the patient often will say, what would you do? And if she asked me that, then I would say I would have it out surgically.
The definite treatment, which is surgery. So we come to an end of our case discussion. Thank you very much, Professor Barlett. We move on to our next session now.